Welcome to Sky Women. I'm your host, Dr. Carolyn Moyers, a wife, mom, and board-certified OB-GYN. This is a place to educate, empower, and inspire. Join us each week as we share the power of women's stories. Real women, real stories, real inspiration. Put on your stretchy pants. Let's get going. Welcome back, Sky community, to another episode of Sky Women. I'm so excited that you're joining us today, and I'm so excited about this guest. I have been watching Stephanie Byerly for quite some time. She is a professor of anesthesiology and pain management and an OB anesthesiologist. And I had the pleasure of meeting her at the Authenticity, Courage, and Empowerment Conference for Women Physicians recently, and said, oh my gosh, I have to have you on. You know, you're doing all the other things as well. Stephanie, I know that you're also a life coach and you have a business specifically for physician healer, which is phenomenal. I feel like as women in medicine, we are so multifaceted.
Absolutely.
So, thank you so much for what you're doing and what you're bringing, in your professional life to other physicians, and also what you do in your everyday professional life and helping mamas to have babies comfortably.
Oh, thank you. Happy to be here.
Yes, thanks for joining us. So let's talk about the elephant in the room, right? Everybody knows that having a baby is uncomfortable. They anticipate some amount of pain, right?
Yeah.
I feel like sometimes mamas feel like they get an extra badge of honor if they do it all natural, right? And they don't need any pain medicine. I personally was one of those mamas because in my first pregnancy, I was in med school and I had done my surgery rotation and I had seen the anesthesiologist with those very long needles do the epidurals.
You were scared.
And I was like, no, not me. I run marathons. I can do this. And it was 8 centimeters where I was like, dear God, where's the anesthesiologist? They could not get there quick enough. And it changed the whole dynamic in the room. Like I couldn't remember what was happening between contractions. I was vomiting with each contraction, like the room became calm and it became a joyful experience. So I love anesthesiologists.
Absolutely. Yes. We're the no pain doctors. We love OB because that's where we actually really can see the results of what we do. And as you said, it does completely change the experience for the mom and everybody else involved.
Yeah, absolutely. Absolutely, it does. And I think that anesthesiologists are a really rare breed and so special because you become, especially in a C-section, you're the photographer, you're the DJ, you were the psychiatrist up at the top, calming the patient, and you're keeping mama alive. Like you're in charge of all the vitals and all the blood products and anything else that we need to do. I mean, we're a real team when we're in the operating room.
Yes, absolutely. And it's such a different situation because most of the time for anesthesiologists, our patients are asleep. Not always, but most of the time, except for OB. So it's a whole, different situation when you're up there, as you said, sort of taking care of everything at the top of the bed and dad too, or whoever's in the room with the mom, just making sure everybody's doing okay.
Right. Yeah, that's a fair point. You've also got a support person at the top of the bed when we're doing a C-section with mom. And then baby gets to go to chest and you're in charge of everybody.
Absolutely. And you're trying to keep the blood pressure cuff on and all the monitors and still have the mom be able to do skin to skin and, watching what's happening over the drape. So it's a very much where have to be very aware of what's going on all around the room.
Yeah, absolutely. You got to read the room.
Yes.
So what was it that attracted you to anesthesia and then specializing in OB?
So originally I did want to be an OB-GYN when I was in medical school. And then when I was doing my OB rotation as a third-year student, I kept looking over the drapes like, hey, what are you guys doing up there? And so I decided to do an OB anesthesia rotation as an elective. And I just loved it and loved all the procedures and just really fast-paced medicine. So I didn't really want to do a specialty where I had to go to clinic and round on patients every day and things like this. I was more of like, I want to give a medicine. I want to see what's going to happen. I want to take
your results, girl.
Yeah. And I really, people said to me, well, do you not want to have long-term relationships with patients? And I said, well, it's just different. I have to meet a patient and within just a few minutes, they have to, trust their life to me. And so I'm really helping people in critical times. There's really not many people who are not anxious when they're going to the operating room, even if it's something they've chosen to do totally electively. And so, to trust your anesthesiologist and know that you can make a total difference for people. But I love OB. Where I've been taking care of very critically ill pregnant women for 7 years. And the sickest pregnant women that you could imagine get sent to our center. Yeah. And it really is, it's a different experience when you're with an awake patient and they may be in labor for, as we know, 24, if not more hours. And you're trying to get them through this and to make this a good experience for them, but to also keep them safe, because I'm not sure, as far as the people listening, understanding that the maternal rate of, not doing well from pregnancy is pretty high in the United States, especially in Texas. And so, it really is balancing keeping them safe and making them comfortable.
Yeah, absolutely. Yeah, you're a big part of helping us in that maternal morbidity and mortality. So mamas who are dying around childbirth, the number of times that I've been called to a maternal code, you better believe I'm like, where's anesthesia?
Yeah, absolutely.
Like we are the two doctors in the room, and it makes a big difference for sure.
Absolutely. Yes.
Okay, well, let's get into some very common questions in your line of expertise. So what is the difference between an epidural and a spinal?
Okay, so just a little education here. So there's a space that's not normally occupied by anything, and we call it a potential space. And so it's the epidural space, and it's the space outside of the spinal cord and the lining of the spinal cord. So it's before you penetrate any layers to actually enter the fluid that's around your spinal cord. So it's before the space around your spinal cord, I guess I would say. So when we get in there with a needle, it sort of opens up a space that's not normally used for anything. And so what we do is we put a catheter in there, and we will give you medicine continuously through that catheter, versus the spinal, which is usually you go in with a needle, and it's usually one shot sort of situation. So you go with the needle, you put medicine in, you get numb really quickly, but you can't add more medicine to it. There is a special situation where you can put a catheter into the spinal fluid, but it's not very common. So normally we think of a spinal as one shot, you get numb, no more medicine, versus an epidural where you can continue to add medicine as long as you need to get the patient numb.
Okay. And so when are you choosing which to use?
So it depends what the situation is. So say, if someone's coming in for labor, we usually put in an epidural. But what's really common now is to do something called a DPE, which is a technical term, but dry puncture epidural. And what that means is we put an epidural in, but through that same needle, we actually put a spinal needle, put it in, make sure we're in the exact right spot. And we take the spinal needle out, and then we just thread the epidural catheter. But that gives us a lot of benefits. One, we know that it's in the right place. And two, it actually helps the patient get better pain control. So sometimes it's sort of a combination.
I see.
And then sometimes, say if you're coming in for a C-section and it was a planned C-section, so you had to have it for a certain reason. Sometimes they'll do this, what we call this one-shot spinal, where you come in, you get the spinal, you get numb up to your breast area. You're numb through the entire procedure. The great part with the spinal and the epidural, though, is we can put long-acting morphine in there that really helps with pain control. And so there's the spinal that they can use for one shot for a C-section, or sometimes what we do is something called the combined spinal epidural, which is when we purposefully do an epidural. We do the spinal again, but then we do put medicine through the spinal that gets you really numb really quickly, and it has this wonderful long-acting pain medicine. We may, put the catheter in so that, say, during your C-section, if you start to feel anything, we can actually give you more medicine through the epidural. So it's sort of like coming in for a procedure, like a C-section, versus if you're coming in for labor. Most of the time, labor will be an epidural. They may do that extra little spinal for some extra medicine, but it's not something that you can continue to redose if it's just a spinal.
Right. So like if you're being induced and this is going to be a while, you're going to want something that you can continuously.
Absolutely.
Medications.
Yes.
Okay.
Yes.
So another common question is Is it going to, like, just this generalized fear around it, right?
Yeah.
Will it hurt when I get my epidural?
So we give numbing medicine, a lot of numbing medicine. And before we start, we just say, can you feel this? Can you feel this? And if not, we proceed. But if you start to feel any pain, we stop and give you more numbing medicine. The thing is that you will feel a funny sensation. So it's like a pressure sensation because we're sticking, a needle in between the bones in your back. But again, it shouldn't be painful. And if it is, you should get some more numbing medicine. But just to know, pressure is something, unfortunately, we can't get rid of. So that sensation is there. So it just feels funny.
Right. And is the medication harmful to baby? I always kind of giggle like this. As an OB-GYN, I'm like, nothing I give will be harmful to baby,
Yes.
But yes.
So the baby does barely, it's so minimal, the trace amounts of anything that we give that gets to the baby. And that's why epidural anesthesia is so safe, because it doesn't get to the baby. And so I think one of the things that people are afraid of is that it's going to also slow down their labor. And there have been all these studies in the literature, scientifically proven to show that it doesn't slow down labor. And we don't make women wait anymore. We used to say, until you get to 3 centimeters or 4 centimeters, you can't have an epidural.
Right.
But now we don't do that anymore. And it is so safe as far as the baby not getting the medication, and it helps mom relax so much more.
Yes.
And so the labor usually kind of progresses.
Right. I agree. If it's going to progress, it generally will progress well.
Yes,
if you're relaxed. Yes. Because oftentimes I've seen mamas who are so tense and so anxious and so uncomfortable, and they finally get that epidural, and then we get to complete,
And so, I will tell you, because I have the benefit as a female OB anesthesiologist when women are concerned to say, look, I've had 3 epidurals myself, and I wouldn't have subjected myself or my baby to something that I thought was dangerous.
Yes,
usually when I say that, they're like, oh, well, that makes sense, because you probably wouldn't have. And so that puts them at much more ease.
Yeah, absolutely. Oh, I'm a huge fan. 4 babies, 4 epidurals. Absolutely.
Oh, goodness. Yes, absolutely.
Yeah. So you brought a couple of interesting points that I just want to bring up. So when you were saying, that they concerned about slowing labor, will I feel to push? That's another really common question. Am I going to be able to feel to push if I'm numb?
So occasionally I will say that sometimes you feel so numb and we have to turn the epidural infusion down, because we usually run medicine continuously through there. Sometimes we have to turn it down until some of the medicine goes away. But for the most part, you can feel the pushing. And again, it's that pressure sensation that's going to be there. And your body, it's such a natural thing that your body is like, okay, even though you can't really feel the pain of the contraction, it's time to push.
Right. The pressure to push. Yes. And
pressure to push.
If they've recently gotten dosed and go to complete, 10 centimeters dilation and they're feeling that urge to push, sometimes it does take a little bit of guidance. So sometimes I put 2 fingers on the pelvic floor and kind of apply some pressure to, let them know this is the direction. But once they get the hang of it and that head comes down, they're going to push regardless of an epidural.
Right. Absolutely.
Yeah.
Yes. And I think there's just so people have been told so many nightmare stories about epidurals. So there's this fear, but they're so safe. Again, I've had 3, you've had 4, I just hate to see women suffering in pain if it's the fear, situation, and we can allay their fears.
Right. Well, because I think that there is a big fear component to it. And I don't know any other procedure, surgical encounter that anybody would have where they would do it without anesthesia. You know what I mean? What other realm of our life would we think is totally okay to suffer through this pain?
No, absolutely. And, there are some women that really come in and they're like, I'm having this natural. And I would say out of 10 women that come in, 1 will make it going all natural. And it isn't, it's not a failure thing. It's like, why suffer? Why?
Yes. So. Agree. And in saying that, I also want to say, I respect your choices, whatever our patients choose. If you want to have a natural labor, if you want to labor in the tub, if you want to have, whatever, nitrous oxide, to have alleviate labor, there's so many choices, and we're going to support your choices in whatever they are. But if you're choosing for some pain control, then we're here to educate you and let you know what the options are.
Yes.
Okay. Now, you brought up something that came to mind when you were talking earlier about the safety of an epidural and how the medicine doesn't get to baby. Well, that immediately made me think of, okay, well, we have to go under general anesthesia. Okay. So that's a unique scenario, right? Where we have an emergency C-section for whatever reason, either mama's crashing or baby's crashing, and mama doesn't have an epidural or a spinal on board. We don't have adequate pain control, and we have to get baby out quickly. Then we undergo general anesthesia. So talk to us a little bit about that.
So general anesthesia is what we commonly do in the regular operating room. So, for any other procedure that you're having done, what happens is when we put you to sleep, we put you to sleep with IV medicine that can go to baby as well. But when we put the breathing tube down, which we have to for this, the medicine that keeps you asleep, some of that does cross over to the baby. But that's why when we do general anesthesia, we are ready to go. So a patient, if they do have to have this, will know that we put up the drape, we make everything all sterile, and then you as the obstetrician and the nurse would be ready to go as soon as we got the patient to sleep so that the baby receives the smallest amount of general anesthesia. And I would have to say that rarely have I ever seen where a baby has come out ultra sleepy or really been affected by the general anesthetic, because you guys move so quickly when we have to do a general anesthetic for that reason.
Right. It typically is a true emergency. And so we are all, it's like it's a beautiful dance, in my opinion,
really
in
is.
the operating room, because everything is ready to go. The minute you say go, we are cutting and we're getting a baby within minutes.
Right.
Yeah.
And so additionally, there are times when someone can't have an epidural or a spinal due to, say, if they're on a blood thinner or if they have some kind of issue as the mom where we can't actually do that. And if they do need a C-section, that we have to electively plan on general anesthesia. Okay. And we do it the same way where, again, everybody's ready to go. We go ahead, get mom to sleep, and the baby is out really quickly.
Right. And we should mention that anytime that's happening, we have the neonatal intensive care unit there. The team is there for baby. So you and the OB-GYN are part of mom's team, right?
Yes.
And then we've got a baby team there as well, because baby will need to resuscitate after coming out of the wound if it's going to have had some exposure to that anesthesia, right? And so it'll be a little bit suppressed, and it's going to need some help, to kind of get going on this side of the world.
That's right. They're like, wait, it's really bright in here and it's not warm anymore. What happened?
Yeah. Where's my warm, cozy spot?
Where's my warm, floaty place?
Okay, so let's talk about when there are complications with anesthesia, like a spinal headache. And another huge concern I hear about is back pain. So I want us to kind of walk through those. Typical presentation of a spinal headache. How often does it happen? What's a blood patch? How does it work?
So it's not very common to have a spinal headache, especially now because the needles that we use are so small. But there are a subset of women that will get them. And it does also depend on how experienced your provider is, to be honest. But when you have a spinal headache, it usually occurs within 24 hours of the delivery. And it's a very distinct type of headache. So when you're laying down, you usually don't have any symptoms. But when you sit up, you're going to get symptoms where you may get neck pain, you get a pounding headache, you may get photophobia, or where the light is very, very difficult for your eyes, nausea. But again, when you're laying down, you don't get the symptoms. It's just when you sit up. And so there are ways to treat that conservatively. We usually don't do a blood patch until it's been at least 24 hours because it's less effective if we do it immediately sometimes. And so you can drink a lot of fluid, have a lot of caffeine, and sometimes that actually will help it resolve, because what it is like there's a little hole where we went through the membranes to get into the spinal fluid, and sometimes the fluid is leaking out. So if you drink a lot, you'll make more fluid and the hole will actually seal. But there is this thing called an epidural blood patch where we do another epidural. And then what happens is someone is back there putting in your epidural, and then say a nurse or a nurse anesthetist or someone who's assisting will draw your blood as the patient in a sterile fashion and then hand the blood back to the anesthesiologist. And they'll actually put blood in the epidural space. And then what it does is it forms a clot over that little hole where the fluid is dripping out of. And normally the patient will get immediate relief. And it's very rare, but there is a rare instance where some patients will need a second blood patch. But again, that is not common. If you do not get a blood patch, though, and you still have the headache, normally it resolves within 7 days. So usually goes away within that time. But we know that, obviously if you have this kind of headache, that be debilitating and you have a brand new baby, we don't want you going home, miserable. We would rather, if there's no reason not to do a blood patch, just to go ahead and get that done.
Right. And what are some instances when you wouldn't do a blood patch?
So if somebody has some kind of issue with their spine and it was really difficult to get the epidural in, you wouldn't want to take a chance of having a problem getting another epidural in and then causing a bigger hole. If you were concerned that the patient had something going on, like in their brain that you were not aware of before, and you're concerned that there may be something else going on, then you may need to do a further workup, like get a CAT scan or get an MRI, or for some reason, let's say they had to put the patient back on, say, a blood thinner, where you wouldn't want to be sticking a needle back there. But most of the time, unless there's some issue, if they got an epidural in the first place or a spinal, they're usually okay to get the blood patch.
Okay, great.
Yeah.
Awesome. And how often does the blood patch work?
Usually it's pretty effective. It's in the 90s. Yes. And again, usually the first one is immediate relief. I mean, they'll say, oh my gosh, my headache is gone.
Yeah.
Because normally they're sitting up when you do the blood patch and you have to ask them like, okay, does your back hurt as you're putting the amount of blood in there? That's when you know how much exactly to put in. When they say, oh, this is a lot of pressure, we got to stop. But usually they're sitting up and then they're like, oh my gosh, my headache is gone. And you can just tell their face. They just feel so great all of a sudden. So yeah, but again, rare, but it can happen where you have to do two.
Yeah. Okay. Yeah. I think working in the OB emergency department, of course, I have seen more than my share of spinal headaches, but that's where all those cases go. So it is always amazing to see the immediate relief, where mom came in just totally debilitated by the pain and leaves cheerful, like it's just excited that she feels so much better.
And you do, though, have to lay flat for a certain period of time after, because we don't want that blood that's forming the clot over the hole to move, because then the headache is going to come right back. So you do have to be prepared to lay flat for like 3 hours, but it's worth it.
Right. Yeah. So if moms have these symptoms, the severe headache, worse when she's sitting, the nausea, the vomiting, all the things going on, the OB emergency department, which so many hospitals now have developed, is the place to go. If you don't have that in your community, then your labor and delivery unit is where you need to go to get
right. Like where I work, we have them come right to labor and delivery, and we do it right there. So yes, but they should be able to take care of you immediately.
Yeah, absolutely.
Yes.
Okay, so let's talk about back pain, because there's always that one or two. I mean, I can think in the last 12 years or so that I've had, those one or two patients who swear that their epidural is the source of all of their back pain from that moment on. Personally, I have not had that. I've been so grateful for an epidural. If anything, it's like the weakened core in that postpartum period where now we're responsible for a tiny human everywhere.
Absolutely.
And the strollers and the car seats and all the things that create back pain.
Right.
But not usually the epidural site. So can you talk to us about is there any validity to this?
So first I will say that as most pain doctors, or a good portion of pain doctors, are anesthesiologists and use epidurals to treat back pain. So, people who have some different kinds of pathology in their spine put an epidural in and put steroids or other medicines through that. Right. And so the chance of that causing back pain due to the epidural is pretty slim. The same thing, goes for when you're in labor. Now, I will say it may be sore for a couple of weeks, like bruised at the site.
Right.
But the chance of it causing any long-term back issue is slim. I never had a problem. I've actually had 3 epidurals and a spinal. But what I think it more commonly is what you're saying, picking up car seats, bending over, changing tables, all the things that you're doing that you were not doing before that you associate with back pain. And then I think also what it is, people hear these horror stories. So they also have these in their brain, like, oh my gosh, this person had back pain. Now my back hurts. And they make that association. But it's extremely rare to have any kind of complications from the epidural, especially back pain.
Yeah, agree.
Long term anyway. Again, a couple of weeks maybe, but after that, no.
Yeah. And it's usually just the bruising at the side. Yeah. But there can be so many things going on. So treating back and pelvic pain in pregnancy and postpartum with hands-on drug-free options, as I do, I see a lot of pathology, whether it's a history of a motor vehicle accident or gymnastics or horseback riding or whatever. I feel like that there's usually a lot going on that can be exacerbated by the fact that our center of gravity is shifting in pregnancy and our abdominal muscles are being stretched and our back muscles are being stretched, right? Absolutely. And then we birth this baby through our pelvic floor and all of a sudden we have somebody new that we need to carry around all the time.
Yes.
And all this extra equipment and all the things. So pelvic floor physical therapy is fabulous for this and really enhancing our core strength and really helping us to function well as a new mama. So I highly recommend that. It's
absolutely
not the epidural that has caused your back pain, but you may have some soreness at the site of your epidural. I think that's a really, really important point.
Mm-hmm. Absolutely.
Anything else that I haven't asked you about that's just really common and you want to relay to moms?
Often, and this will depend where you're going to deliver, but they ask about eating and drinking. I would say that it's the mainstream now to at least let moms have clear liquids during labor. And that would include things like, I would say pulpless. So, but things like juices, what would we give is like apple juice, we do cranberry juice, we'll do Jello, we do frozen popsicles. So, things like that, because we actually don't want the mom to be in starvation mode. We want them to have energy. So we want them to have carbohydrates. And so, being able to drink, as we call it, clear liquids is something that I would definitely for women, unless you're high risk where there may be a reason that you can't have that. For the most part, I would make sure that where you're going, they would be able to offer that to you.
Yeah, that's a nice point. That is always a big question. And then if we're going for surgery, sometimes there's a delay because of when mama's eaten. Can you kind of talk to us about that and what that means?
Yeah. And so when we are in the regular operating room, say you're going to have a surgery at 7:00 in the morning, they'll tell you nothing to eat by mouth after midnight. So no solid foods, but you can have clear liquids up to 2 hours before. And that's what we do with moms now that come in, say, for what we call elective or scheduled C-section.
Right.
So if your C-section's at 9 a.m., you can have some clear liquids up till 7 a.m. The issue comes in when, say, all of a sudden, say you're having a big old dinner and you're at Whataburger, right? And all of a sudden you go in labor and you need a cesarean section to say it's a repeat and you're like, oh my gosh, I just ate. So if you come in and you need a repeat cesarean section, say you're not really in any pain, you have to do the surgery. But if you ate recently, we're going to try to wait 6 to 8 hours if we can. So if you're not in labor, if your cervix isn't changing, we're going to wait as long as we can, because the risk is in that instance, if we did have to get you to sleep, we'd be concerned if you ate pretty close to that the food could come up out of your stomach and go into your lungs while we get you to sleep. And again, that's rare, but it is something that can be life-threatening. And so that's why we're so specific for all surgeries about solid food, especially for pregnant women, because they're at a little bit more risk. As you can imagine, with their tummy being really big, all that extra pressure on their stomach, we're getting you to sleep. You're not able to really, you're so asleep that you can't protect your airway. So if something came into your throat, you can't cough while we're getting you to sleep. So we just want to make sure that it's been as long as possible before we get you to sleep. But if we have to, we have to, and we do it safely. But, we always try to err on the side of caution if we can.
Right. Absolutely. Do no harm first.
Yes. Do no harm. Yes, absolutely.
Fantastic. Well, thank you so much for chatting with us today and for answering all of our OB anesthesia questions. This has been a lot of fun.
You are so welcome. Thank you so much for what you do and for, answering all these questions and hopefully allaying some fears here.
Yeah, absolutely. Until next week, be well.
All right, Sky community, thank you for listening to another episode. This episode was sponsored by Sky Women's Health. As a reminder, we're in the Dallas-Fort Worth area, and we help relieve back pain and pelvic pain in pregnancy and beyond. If you are pregnant and having pain and you feel like you have no reliable way to relieve it, look us up at skywomenshealth.com, request an appointment, and we'll call to get you scheduled. As a board-certified OB-GYN with a neuromusculoskeletal medicine fellowship, I help you realign with hands-on drug-free treatment and relieve pain on the spot without medication. We'll help you maintain these results through your pregnancy and postpartum period. Every pregnant person deserves this, and we are so excited to serve you. You can find us on our website, as mentioned, or on social at Sky Women's Health, or you can call the office at 817-915-9803. That's it for today. Until next week, be well.